that discussion then brings us to the point of when do you choose then a first-generation TKI, imatinib, or a second-generation TKI? We have two approved, dasatinib and nilotinib. So, Kevin, in which situations would you choose one versus the other? How do you go about this?
Yeah, well, I agree 100% with Harry. I really, when I have a newly diagnosed patient with chronic myeloid leukemia, I look to see what drug can prevent progressions to accelerated blast phase disease. And certainly it's been shown in two large randomized controlled trials that second generation TKIs have fewer progressions to accelerated blast phase disease compared to Gleevec. All three drugs are very effective, but there is a slight benefit to the second generation drugs. Certainly the second generation drugs are slightly better tolerated as well compared to Gleevec. So if I sit down with the patient, we have a discussion, very much a two-way street, and I assess the comorbidities of the patient. If they have a certain number of comorbidities, I may shy away from one TKI compared to the other. But all things being equal, I try to offer second generation tyrosine kinase in the upfront setting. Now, if I was in a resource poor setting where maybe we're looking at a year or two time when Gleevec is available as a generic form, we may be in a situation where we offer Gleevec as a frontline treatment and then switch to second generation tyrosine kinase inhibitor if we're not reaching predefined endpoints. So that could be another potential strategy. But certainly for the higher risk patients, higher risk SoCal score, there is definite evidence that those patients have a higher chance of getting into a major molecular response, into that safe haven phase at the 1 year time point compared to the first generation TKIs.
Mm-hmm, mm-hmm. Okay. And one of the advantages that we've seen in all these studies, in the randomized studies in particular, dasatinib versus imatinib, nilotinib versus imatinib, is these deeper molecular responses, and they are achieved faster. So, I mean, you look at these curves and the deeper responses, they separate very early and all of that. What does that mean? David, can you tell us, is there relevance to achieving these early responses? If, maybe you get to them at the same, to the same level, but later. Does it matter to get deeper and faster? What can you tell us about that?
Some people would argue that it doesn't matter because if you get to, say, MMR after 9 months, or if it takes 12 or 15 months, eventually you get there, and that's what's important. But I would argue on the other side, and I would echo what Harry and Kevin has said, that to me, the prevention of progression to accelerated phase of blast crisis is the most important endpoint clinically. I have a zero tolerance approach in my practice, meaning I want to do whatever I can to minimize the risk of a patient progressing. And that means using a second generation TKI up front, because the risk of progression to accelerated phase of blast crisis is lower. It also allows you, with a deeper, faster response, you more quickly reduce the substrate of remaining residual leukemic cells that are at risk potentially to evolve mutations, which then can make it more complicated to treat the patient later. But in terms of risk stratifying from the NSND and the decision trial, my understanding is that the events that occurred in terms of acceleration to accelerated phase blast crisis were in patients who were intermediate or high risk on SoCal or by Hasford, respectively. So certainly for a patient who is intermediate or high risk by SoCal at diagnosis, there's no question that I would be using a second generation TKI. For a patient who is low risk, you might make more of an argument that imatinib could be appropriate, especially if you're ready to make a change if you don't reach the desired milestones.
I'd like to add something to that discussion, though, about these deeper responses. And I agree with everything you said about where we are right now. But for the future, the other potential for getting deeper responses is all this discussion about TKI discontinuation or treatment-free remissions. So of course, we don't recommend in routine practice to discontinue TKIs when a patient becomes negative on your sensitive quantitative PCR. However, there are situations, especially in younger patients, where we might still consider it. And the specific situation I would bring up are young women who want to conceive. And we're all nodding our heads because we've seen this. It's a very common question. So one potential benefit of a second-generation drug is that you get into quicker, deeper responses. In fact, with both dasatinib and nilotinib, the numbers about 50% of patients will go into a complete molecular remission using the assays that are typically used now. And so that might be a situation where we might feel a little bit more comfortable monitoring a young woman very closely while she attempts to conceive and carry a child.
Yeah. Now, we're talking about these deeper and faster responses. What is deep and what is fast? David, let me ask you, because you brought up the point, and,
Yes.
and I think we all kind of agree that deeper and faster is good, but what is it?
Well, I think the depth of response that I would like to achieve is MMR, the 3-log reduction, because I think that's been shown to be clinically relevant, that the patients who achieve that level of response have a very low, if not zero, risk of progressing to accelerated phase and blast crisis. So that's my initial goal. And how fast, with the second-generation TKIs, you can get there sometimes by 6 months, 9 months, typically. And again, that shortens the window of time that patients are exposed to the risk of progression, and also more deeply, quickly reduces the remaining pool of leukemic cells that are left.
However, David, you don't think that the assessment of early molecular response at 3 months also is a nice marker to predict overall survival and progression-free survival, as many trials have shown?
For sure, and reaching 10% or below by 3 months. But I think that most patients would probably reach that, whether with imatinib or second generation. So I'm not sure that's enough of a discriminator in this regard.
And you brought up this point.